Um, Ladies and gentlemen, members of the commission, included in your packets are copies of the minutes from the November 16th meeting, the public meeting of the commission, as well as minutes from the October 6th commissioner retreat. If there are no changes or corrections, I'd like to entertain a motion for approving the minutes. Motion, do I have a second? Second. All those in favor, say aye. Ayes have it. Very good. Commissioners, you've also received written updates from all of our centers. You've had an opportunity to read them. Commissioners, do you have any questions for on the written updates that you received for any of the staff? Anyone? All right. David Sharp, you'd like to provide some information to the commission on the new telehealth grant announcement. Is that correct?
A couple announcements, but first, let me, on that, along the agenda item, invite up my colleague, Angela, to talk a little bit about the announcement, and then I'll go on to the second item.
Sure.
Good afternoon. So center staff plans to release a telehealth grant announcement early January to increase access to medication-assisted treatment, or MAT, to underserved Maryland residents with opioid dependence through telehealth interventions supported by mobile devices and integrated care delivery approach. As you know, the number of deaths national from opioid drug overdose more than tripled between 2000 and 2015. Maryland specifically, opioid-related deaths have increased about 75% from 2007 to 2015. In its response to the growing epidemic, on March 2017, Governor Hogan signed an executive order declaring a state of emergency. Since the opioid epidemic has become a public health emergency, certain medications have been recognized as an important tool for comprehensive opioid treatment services. MAT, an evidence-based service for treating substance use disorders that combines medication like buprenorphine with behavioral health services, has proven to help retain patients in treatment, reduce relapse, increase recovery rates, and save lives. However, only about 10% of individuals who need such treatment access it, particularly due to the stigma of receiving treatment in a specialized program and the location of these programs. In an effort to address access issues, the Drug Addiction Treatment Act of 2000 was enacted to allow for prescribing and dispensing of buprenorphine in an office setting outside the specialty licensed opioid treatment programs where patients may feel more comfortable. However, many practices are reluctant to prescribe buprenorphine due to the lack of time, concerns about negative reactions from the current patients to the community, inadequate staff support, and worries on DEA investigations. Statewide, a shortage exists of prescribers of buprenorphine, which results in some patients needing to travel long distance to receive MAT. Studies suggest that the medication treatment of an opioid use disorder via telehealth can be just as effective or even more effective than in-person treatment. And telehealth supported by mobile devices can play a key role in increasing access to treatment by virtually connecting the clinicians to a patient at a clinic or a primary care practice. Substance use disorders are often interceptively intertwined with health issues, each exacerbating the other. An ideal care delivery system is one that is fully integrated, where care is coordinated among primary care specialty and behavioral health providers with necessary community support. This integrated approach is the focus of several state quality improvement initiatives, including the HSCRC's total cost of care model and the Maryland's primary care model. We believe this grant announcement aligns with those models. So we're planning to fund up to $150,000 on a competitive basis, a single applicant over an 18-month period, to implement an innovative telehealth project that optimizes MAT with buprenorphine to expand treatment services in underserved areas of Maryland. The goal is the grant is to increase access to licensed healthcare practitioners with expertise and legal authority to provide MAT with buprenorphine, support somatic and behavioral health care professionals in addressing a needed service for their patients through an integrated approach and increased treatment retention and decreased positive drug screening. There will be a required one-to-one financial match. In terms of next steps, we're planning to reach this announcement, as I mentioned, early July. Applications will be received in February, and we're anticipating announcing an award in April.
Thank you very, very much, Ms. Abbott. David, you have another observation?
Sure. Thank you, Angela. I want to give you all a brief update on the status of the advanced directives regulations that you all may recall. So this stems from House Bill 1385, which is the Public Health Advanced Directives Procedure Information Sheet and Use of Electronic Advanced Directives from the 2016 legislative session. In the statute, it requires MACC to develop a state recognition program for electronic advanced directive services. You all approved as proposed permanent COMAR 102519 state recognition of electronic advanced directives during the June 15th commission meeting from the summer. On July 14th, the promulgation of all regulations was halted by the Regulatory Reform Commission. In early December, we learned that the regulation was approved to proceed, and we plan to release COMAR 102519 for publication in the Maryland Register on the 22nd, tomorrow, right? Staff plans to bring back the regulations to you all for final action during your February 15th meeting. And at that time, hopefully, we will be able to move forward with plans for the final effective date being March 12th of 2018. With that, I'm happy to answer any questions, and that concludes my addition to the update. Thank you, Mr. Chairman.
Any questions for Mr. Sharp? Any at all? Mr. Director, you have some announcements?
Thank you, Mr. Chairman. I wanted to, first off, briefly outline the status of the total cost of care demonstration. As I mentioned, it had moved through CMS and is currently under review by both the acting health secretary at HHS and is also, I understand, under review at OMB. Although we had hoped that the action would be taken on the model, including both the total cost of care model and the primary care program by the end of the year, it looks like that is increasingly unlikely. But we understand from our colleagues at CMMI that progress is continuing. We will be informing the commission. I'm certain that there will be a press release from the governor should it happen should the program be approved over the Christmas holidays. We are also, as part of that work, continuing to work with the CMMI team and our colleagues at the Maryland Department of Health on the primary care initiative that is part of the total cost of care demonstration. We've had 4 outreach sessions across the state attended by upwards of 100 providers or more. Most recently, last night at Sinai Hospital here in Baltimore, we, with the department, with CMMI in attendance, presented an overview of the program to more than 125 providers and provider representatives. Interest is high in the program. Depending on approval, the intent is to launch the program on July 1st, but certainly if the approval is delayed, we'd want to reconsider launch depending on how much time we need to issue solicitations and select practices. Those activities will be completed by CMMI. We are working with the department. The department is taking the lead on this effort, consistent with our discussions with commissioners. We are supporting the department, principally working with practices in engagement and transformation should the program be approved. Our work with Where the Cost has continued as we had a very successful rollout at the end of October. We did get some feedback and questions from the Maryland Hospital Association as well as MedChi. We met with both of them over the interim and have agreed to establish a broader advisory group that would include MedChi, MHA, and consumers that would advise us as we move to the second iteration of the Where the Cost initiative, which will be rolling out privately insured claim information for 15 and 16 in the first quarter or early second quarter of 2018. At the same time, we'll be moving forward with working to make Medicare data included in this initiative. We think it's a very powerful effort, and it's engaged consumers, I think, in a new way, focusing on information they can use. Our work with the Network for Regional Health Initiatives, their total cost of care effort also will be coming to launch in January of this 2018. As last year, the results from Maryland in comparison to 6 other comparison regions look quite favorable. Our total cost of care is lower than the other 5 regions as it was last year. We have some reasons for that, particularly the all-payer model seems to be something that allows private payers to negotiate to have more favorable hospital rates than their colleagues in other regions of the country where they individually negotiate with hospitals for payment. There are a couple of procurements that I wanted to, David mentioned one, a second one that has been released is for, we are seeking a vendor to assist us in estimating the needs for the primary care workforce should the total cost of care model be approved. As I've said a few times, this model envisions a greater use of primary care providers, both physicians and others. The results here in Maryland to date, although we have a significant physician workforce, the distribution between primary and specialty care is not necessarily optimal for a model such as total cost of care. And so I think it is useful at the outset that we look at supply and demand under both current law and should this model be approved, and may therefore have the opportunity to adjust efforts to train more primary care physicians in some instances, recruit more primary care providers in others, but know as we start this model and begin the 10-year march to completion, what we're really going to need to achieve that. That effort will use, I think, recent advances in workforce studies that will be beneficial to the state. And lastly, I wanted to announce today that Karen Rezabek is attending her last commission meeting. She will be retiring at the end of the year. And Karen has really served the commission from the very outset with enormous devotion, commitment, and flexibility. I have a saying that I tell people that success is not a solo act. And although Karen has not been up at front of us often, she has been instrumental in many of the successes that the commission has enjoyed over this past 18 years. She will be very sorely missed. Her willingness to jump in on any issue and sometimes to jump in on an issue and give up responsibility on another because we needed her more elsewhere has been something that I think we all can celebrate, and really, as she retires, wish her very much the best of luck and hope that she stays in touch. So thank you, Karen. And
Karen, would you stand, please? Thank you. Thank you very much, Karen. Thank you very much. Commissioners, do you have any questions for the director? Any questions at all? Okay, let's turn to the next item, which is a change in an approved certificate of need for the Grove Neck Road facility run by the Recovery Centers of America. Last year, the Commission approved 3 CONs for the Recovery Centers of America to establish 3 inpatient substance abuse treatment centers. This agenda and the next one that follows involves requests by the Recovery Centers of America to increase the approved project costs associated with 2 of these previously authorized CONs. The applicant is appearing before the Commission today because both projects will require more than a 10% increase in the project cost. The changes are needed because of higher than expected construction and development costs. The first project is the Recovery Center of America at Bracebridge in Earlville, in Maryland. Kevin McDonald, who is the chief of the CON division, is going to present the staff recommendations. Kevin, thank you very much, and the floor is yours.
Thank you and good afternoon. As the chairman said, RCA Earlville is in front of us today because its capital costs are now projected to exceed the inflationary allowance. To recap just a little bit, RCA is a relatively new entrant to the addiction treatment business, currently operating in Massachusetts, New Jersey, and Pennsylvania, is currently operating at Earlville and has 2 other projects in Maryland that are under development. This particular project is a renovation of an existing facility as well as an addition to that facility. It would create 21 intermediate care facility detox beds, level 3.7 and 3.7D on the ASAM, that's the addiction medicine, thank you, on that scale, and 87 residential beds, 3.5 on the ASAM scale. We regulate only the 3.7 and above, and that split is part of what I'll be talking about in the cost increase that we're talking about here today. The approved cost originally for the entire facility was about $32.6 million. For the regulated ICF portion of the facility, it was about $5.6 million. It was going to be financed with equity funding, private equity firm funding of $4.5 million and a mortgage of $28 million. The facility actually opened in October of 2016 on the unregulated, in some of the unregulated portions of the facility. And after its approval, approached MHCC in February of this year and was authorized to provide detox services temporarily in some of the space that was residential space, because that space was ready to go. The detox space was in the renovation area. So they were authorized to temporarily begin detox treatment in that space as well. And since the October 2016 opening, the facility has served, and through November 20th, about a month ago, the facility has served a total of 533 patients for over 8,000 patient days, and 744 of those days, or 9%, have been charity care. As I said there, before the commission, because of a cost increase in excess of the inflationary allowance, the total cost goes from about 32.5 to 42.5 million, and the regulated portion from about 5.6 to 7 million. Essentially, construction costs were underestimated, and that accounts for most of that increase. In terms of our CON is tied only to the regulated portion. And their request for an increase in their allocated CON allowance is not only to reflect the increase, the absolute increase in costs, but also to account for a misallocation of costs that occurred in the initial approval. Essentially, the reason for that misallocation was that this project changed several times. The ratio of intermediate care beds to residential beds changed multiple times. And in the end, the allocation didn't catch up with what it ended up being. The current proposed allocation methodology would say that any cost that is attributable to the entire project would be a 19% allocation, essentially the ratio of intermediate care beds to total beds. And if it's attributable only to the new construction where the detox beds are occurring, it would be a 30% allocation, because that in turn allocates the proportion of ICF beds in that location of the facility. Hope I haven't been too confusing with that. In order to increase the, or to meet this increased cost, the mortgage will increase to $36.6 million, and the equity funding will increase to just under $6 million. In terms of the staff recommendation, staff does not believe that the requested modifications would have an effect on the earlier findings that the commission made. Since the project is really not, the nature of the project is not changing, the location is not changing, it really doesn't change your findings based on need, your findings on need or impact. In terms of viability and feasibility, the private equity investor has indicated its willingness to extend the additional funding needed. And on the operating side, the increase in project costs will not be reflected in revenue or expenses, as the additional cost will be borne by the parent company and not charged back to the operating entity. Accordingly, staff recommends that the commission approve the proposed changes in RCA Earlville to include both the increased costs attributable to the initial underestimation of project costs, as well as the costs attributable to the reallocation of those costs. Staff also recommends that the original conditions placed on this CON would remain unchanged. Here today, representing the applicant, is J.P. Kristen, the Chief Operating Officer of RCA of America, and Ella Aiken, their counsel.
Welcome. Commissioners, are there any questions for Mr. McDonald? Commissioner?
Well, I had a question, and it really is not about this application. I don't have any concerns here. If in evaluating this, should I be looking for a cost increase that's so significant that the project is no longer viable? Is that what we're looking at here? And we're just saying it's not an unviable project, so we should not be concerned and go ahead? Is that the analysis that we're following? I'm trying to gauge how concerned I should be. So the cost has doubled. It's unfortunate for them, but maybe it doesn't rise to something we're concerned with. What are we looking for? How much should costs be going up before we're concerned? Is it viability of the project that we're talking about?
I think when staff looks at it, it would be, yes, exactly that. Does viability remain based on that cost increase?
Okay, thank you. And like I said, I have no concerns with this.
Right. Any further questions? Yes. Commissioner Phillips.
Your report. This is not directly on the point before the commission right now, but it does relate to RCA Recovery, RCA Recovery America. Since this commission has heard from this applicant, which I think was most recently in February, is that right? Or maybe that was the staff interaction.
That was a staff action.
All right. Well, the point is that, came to my attention that over the summer, there were some very disturbing actions that the state of Massachusetts took against this company with regard to, very serious health and safety violations requiring an immediate shutdown of, I think, one, maybe two of the Massachusetts facilities, in part because of understaffing. And so I guess my question is whether the facility, the spokespeople here for the corporation can speak to the level of quality, maintaining the level of quality, maintaining the level of staffing that's necessary to ensure the safety and effective treatment of patients here in Maryland, given this pretty startling disclosure in the Boston Globe.
Mr. Kristen, thank you very much.
Short.
Hi, I'm JP Kristen, Chief Operating Officer of Recovery Centers of America. So you're referring to a fairly sensational article in the Boston Globe. We have two sites in Massachusetts, one called RCA Westminster, the other called RCA Danvers. RCA Westminster has been up and running the entire time with 48 beds since it is opened. RCA Danvers was the subject of some additional review by the licensing body in Massachusetts. In order to expedite the review and move past, any sort of issues, we voluntarily surrendered our license for both detox and residential beds, reapplied. They've been through two subsequent licensing surveys, so we've had our both detox and residential locations surveyed, and we're told we'll be open with 55 beds, in early January. So that's the latest update related to those allegations.
Mr. Mayor, with respect to the question regarding the Maryland facility, I would reiterate what, as Kevin McDonald was explaining, their Oldville facility has been open since October of 2016, and RCA has been compliant and meeting all the staffing requirements imposed by Maryland regulations. The facility has been successfully running, good volume of patients, but also high satisfaction scores. We provided survey scores to Mr. McDonald. I believe those are continuing in report. So we're confident the facility is not only compliant, but also serving the needs of patients.
We've been surveyed by the Joint Commission at all of our locations and passed the survey. I mean, if there's an issue, we have an electronic health record. And if any of you have dealt with electronic health record, it requires all providers to input necessary information. Not at all times did we have that information input the way that it should have been. So when the nature of responding to inquiries is that we'll have the review. They'll ask for you to respond on your corrective action on a prospective basis, and that's what we did. And we didn't necessarily dispute the findings of the surveyors when we probably should have. So we've subsequently provided all records with regards to staffing and medical record documentation. Again, I don't really think there's any outstanding issues. We just had to go through the process again to make sure that when they surveyed us that we're meeting all the requirements in Massachusetts.
And that's true also with the state licensing, the Office of Healthcare Quality, as far as the facilities licensing requirements.
In Massachusetts, we're talking about?
Maryland.
In Maryland, we're meeting all requirements and we've not had any issues.
Any further questions? Dr. O'Connor.
Is there a pattern across your corporation where you underestimate the cost of construction, since this issue and next issue is the same issue?
I'm not going to say that it's a pattern. What we've discovered in building our sites from Annapolis to Boston, that the economy is such that there's a lot of commercial development and subcontractors are very busy, and most of the bids that have come in have been higher than we would have expected. Our projects cost, and so we've seen like increases from again Boston to Annapolis.
Any further questions? Commissioner O'Grady.
This is really for Mr. McDonald. This is certainly not the first time we've seen kind of an amended
CON having to do with an underestimate of building costs. Is there something that we should be looking more systematically at the methodology that's used, if it's, or are there simply any number, kind of a balancing number of overestimates of what it would cost that we never see, and therefore we only see the ones that are sort of underestimates? Is there a, should we be taking what is their experience has been, you know, the subcontractor's estimate of what this will be or what they think it'll be, and multiply by 1.2 or something, just to be sort of safe that we're, that, and, you know, these people have to come in and do this all over again for the, you know, it's bureaucratic, it's slow, and it's inaccurate. Is there something we should be looking at more systematically to get more realistic estimates?
Our methodology, and it's not employed in every facility, and I don't recall if it was employed in this review, because it's not in the standards for this review, but the Marshall, you might have heard us talk about the Marshall evaluation system. That is used in all hospital reviews and ambulatory surgery reviews. It lends itself to some projects much better than others. We've discovered in ambulatory surgery, additions of a room, it doesn't work real well. It's also, you know, a fairly abstruse formula, and if it's not something that you're highly versed in and working with all the time, it can be very difficult to work on. So, you know, could we come up with a better one than that? I've actually tried to reach out to that company to see if we could subcontract with them to do those reviews. And while they were initially interested in that, they haven't been responding lately to follow-up emails or phone calls. Is there a better way to do these estimations? In some states, the CON agency either has on staff or contracts with construction engineers to look at estimated costs. And I understand somewhere in the past, Maryland had that resource, but no longer does. So, you know, could we be better at that? We probably could. And we'd have to look at, you know, the best way to do that. But, you know, some projects are much different than others. These RCA projects are retrofitting old facilities and, you know, varying types of facilities. And I think when you're making those kinds of cost estimates, there's a lot more room for error than there is in, you know, a greenfield project.
Okay. I mean, I think we've all worked in different, you know, aspects where you have instruments that are more or less accurate. And I guess just as, I mean, I'm not suggesting you have to scrap this or find somebody totally different, but perhaps just as you and the staff consider it, there's sort of a wider confidence interval depending on the type of facility and your confidence in the model's ability to accurately predict. Just so that we work in a little cushion here in terms of what our expectations are.
Unfortunately, next month we're going to have a nursing home before us who you approved a modification for about a year ago for a fairly significant cost increase. They're going to be back in front of us for a second cost increase.
Commissioner.
And, you know, where these real, I'll finish this thought.
Go ahead.
Where this really, I think, is important is when you have competing applications, such as if we had essentially enough nursing home beds, need for enough nursing home beds to build one nursing home, and we had multiple applicants for that. That would be where having an accurate cost estimate would be more critical than in an instance, maybe like the one you're going to see next month, where this comes out of the hide of the provider. They're not getting paid more by Medicare or Medicaid because of their ineptitude in estimating or building. So I would say, you know, some instances deserve a higher scrutiny than others do. And certainly a competitive application, we'd want to be able to do that. Otherwise, you know, we're looking at viability, and if public funds are involved, you know, it's really important to be good at that too. If public funds are not involved, you know, it's more on the back of the entrepreneur.
Yeah, I think that's a great point. And I was going to add that I think the CON was filed in 2015. So at this point, the facility's been built. You know, are you going to guess 3 years out exactly what the cost is going to be? Kind of depends on how busy your contractors are, right?
Well, I mean,
If I hear what
the
happened.
cost estimate that was
It's
provided,
gotten expensive to build something because they're busy. So in 2015, you'd have to predict how busy your subcontractors are all going to be 2 years later.
but the cost estimates were updated as the applications were updated, so.
Yeah, but there's still going to be that, you know, it's still a different environment this year than it was last.
You know, an economic cycle. It's clearly you can do this cheaper in the middle of a recession because people are looking for work at the same time. And it's not so much, I mean, I would just, for us to make accurate policy decisions, and it's true that we want to be more careful if there's direct taxpayers, but we know that this adds to the overall cost of care. This money isn't, I mean, some of it, if we're really lucky, comes out of reduced profit margin by people, you know, by someone else than the taxpayers or the subscribers and enrolled members of the insurance plan. But the reality is it's adding to total cost, and we would just like to, and that's quite often quite appropriate. There's nothing like that. I think what I would like anyway is just, and I just, you know, I come out of a federal experience where things constantly seem to overrun, and it was sort of like, then why don't we take your best estimate and multiply it by 50% more? You know, I mean, there's a whole field of statistics that says your best estimate, and then what is the Bayesian adjustment, which is basically, you know, these things always estimate low, or these things always estimate high. So I would just like to, I'm only arguing for accuracy into the decision-making process, not
It's
good,
something we
bad,
can,
or indifferent on the other aspects of it.
something we can and should give some thought to how we can fine-tune that process.
Commissioner Pollock, you had a question.
Yeah, I appreciate the discussion around how we prevent this from coming back to us a second time when cost estimates go high. I'm trying to figure out why it needs to come to us the first time. Is there some belief somehow that if we build too many recovery centers, we're going to have too many patients, too many addicts, or we're going to increase cost of care? It's generic. It's a rhetorical question, I guess. I think this is an area where we really ought to think about in the future, whether we want to change our CON process to sort of exclude centers like this, or look for statutory change if it's possible to avoid it. But this is, it just seems, it seems like I can't come up with a good reason why we should be adding cost to the process by doing what we're doing here. Because it's clear it costs you money to file the application in the first place, to go through that process, to go through this revision process around something we've already approved for an increased cost that's coming out of your pockets, not ours, not the state's. It seems like a little bit of insanity to me.
All right. Yes, Commissioner Thomas.
Well, I think that we opened, in fact, Commissioner Phillips, I think, has an opportunity because they're back here to raise a very important question with regard to quality. And so we have a number of responsibilities that this process helps keep in check. I would not want to see it go away.
I would argue that that doesn't do that. That we check quality once in this process on the front door when it comes in, and that there have to be other quality measures in place that check it on an ongoing basis and make sure that things don't change the day you open the door. And, you know, our ability to use, you know, your last center to monitor, to check your next center is incomplete. There are accreditation processes that you go through on a regular basis. There are state quality processes that go through that may or may not need to be augmented, but our ability to just check it on the front end is inadequate. And just to use that front door check to add this much cost and this much difficulty to projects doesn't seem to be effective. It seems to be regulatory burden in the way when we could, if we need more quality check, we ought to be investing in it in the longitudinal end of things, not in just the front door. Because the longitudinal end has a front door also. You have to get accredited the first time. So we're adding 2 front doors to a process and nothing in the back for us.
Any further questions? Mr. Kristen, Earlville, you're in Cecil County, is that correct? Grove Neck, is that, this is an area, this is a rural area, that's what I understand, is that right? Fairly rural? Yeah. Across the Sassafras River from Kent County.
Yeah, the property actually, borders on. The property is around 500 acres and borders on the Sassafras River.
All right. Very nice real estate. I'm somewhat familiar with it.
It's a nice, peaceful
Okay.
location.
Yes, it's a beautiful area. Any further questions? We have a motion then to approve, I need a motion to approve a change in the certificate of need for the Grove Neck Road Facility for the Recovery Centers of America. Do I have a motion? Motion. Do I have a second? Any further discussion? All those in favor say aye. Any opposed? Thank you very much. Mr. Kristen, you have your certificate of need.
Thank you.
All right. Our next topic is the certificate of need, a change in certificate of need for the Billingsley Road facility. Again, Recovery Centers of America. The second Recovery Centers of America project here is seeking an increase in the approved cost of a new alcoholism and drug rehabilitation center. It's the project is located in Waldorf in Charles County. Mr. McDonald will present the staff recommendation.
Essentially, except for the change in the numbers of beds and the cost numbers, this is the same, it's a rewind.
Okay.
And the staff review and recommendation really hit the same points.
Exact same issue. All right. By the way, in terms of the actual increase in the cost, what are we talking about?
Okay, yeah, let me do that.
Just briefly.
So the total cost goes from 28.7 to 36.5 million. The regulated portion, a larger percentage of the regulated portion is affected here, though. It's from 10.7 million to 16.8 million.
Okay.
Same issue, a basic cost increase, and then a reallocation because the numbers of the ratio changed throughout the process.
Okay. Thank you very, very much, Mr. McDonald. Commissioners, are there any questions? Mr. Director?
So I did, and this would be for RCA, and given, I should have asked this question earlier, but actually it's more relevant to this facility than Earlville. Last year, the Medicaid changed its policy for reimbursing inpatient detoxification, and I know that when we first considered this, that wasn't going to be an option. I know that now Medicaid can participate, so that from transparency's sake, I know that up to this point, RCA has not been able to work on an arrangement that you thought was feasible with Medicaid to treat Medicaid beneficiaries at this in the future at this facility. Could you just briefly update us on where those stand? Have those negotiations ended, or is there still, do you believe, opportunity to talk with the department? I know that certainly the Medicaid population, more than 1.3 million in the state, does suffer from opioid addiction and would find this inpatient treatment center beneficial.
I can't answer that, Ben.
I think that's for Mr. Kristen.
Thank you again. Hey, Ben. So, with the Earlville facility, we had a fairly small licensed bed portfolio of 39. When we complete both of these projects, we'll have, a larger capacity. Our current payer mix has been largely 80 to 90% commercially insured with a small self-pay percentage. We've also rendered almost 10% of our bed days now for free care patients or those that can't afford treatment. With the new changes in Medicaid reimbursement, when we have more capacity online, we'll look to see if it can make sense to be able to expand the patients that we can treat. And clearly, it's going to be related to the costs of care and then what the reimbursement will be for the cost of care. I am pleased to report that we've made great progress with the largest commercial payer in Maryland, and we'll have a contract with that group the first of the year.
Okay, the issue, is there any further questions at all? No further questions? Okay, the issue for the commission is a change in the approved certificate of need for Recovery Centers of America, their facility at Billingsley Road. Do I have a motion to approve? Motion? Second? Very good. Okay, any further discussion on this CON? All those in favor say aye. Aye. Any opposed? The ayes have it. Mr. Christensen, you have your change.
Thank you. I'd like to thank the commission. Thank you for the questions and the thoughtful review. And I know commission staff, especially Kevin McDonald and Paul Parker, spent a lot of time on our two requests, and we appreciate that also. Thank you very much.
Thank you very much, Mr. Christensen. Thank you so much. Okay, the third item is the certificate of need, again, for the Coastal Hospice and Palliative Care program. It has applied for a certificate of need. Coastal Hospice has applied for a certificate of need to undertake a capital expenditure of approximately $7 million to establish a 12-bed hospice house in Worcester County. The project requires a CON because the project exceeds the $6 million capital threshold for non-hospital capital projects. The project will serve as a residence for hospice patients receiving in-home hospice care and also provide space for community outreach and other needs of the general hospice program. Mr. McDonald, again, will present the staff recommendations. Kevin?
Thank you. To introduce you to the applicant, it's a general hospice that's been in operation since 1980, based in Salisbury, the sole provider of hospice care in the 4 counties of the Lower Eastern Shore: Dorchester, Somerset, Wacomico, and Worcester. They operate a general inpatient hospice facility in the Deer's Head Hospital Center and also work with Peninsula Regional Medical Center in a palliative care partnership. They served over 1,100 patients in the latest fiscal year, had an average daily census of 198, and had 245 general inpatient hospice admissions. They are proposing a 12-bed hospice house in Ocean Pines in Worcester County by renovating property that they purchased for $1.5 million. With an addition to that building, it would comprise over 2,200 square feet on 3 floors. In addition to the hospice residence, it would house the home hospice team assigned to Worcester and Somerset counties, provide space designed for bereavement counseling and groups, volunteers, social workers, as well as a community room for conferences and community education. As Mr. Chairman said, a hospice house is not categorically regulated under certificate of need, and the reason that we're reviewing this is because it exceeds the capital expenditure limit. The total estimated project cost is just under $8 million, and I would note for Commissioner Pollack especially that the project budget has no CON consulting costs in it, despite the fact that I would say it's one of the more solid applications I've seen. The sources of funds include a mortgage of $4 million, cash of approximately $2.7 million, philanthropy of about $750,000, and a state grant of $500. Reviewing the project against the state health plan standards, it met all standards. There are a couple of things I would want to call out for your attention. One is charity care. Coastal Hospice's financial statements show that it provided charity care in excess of $430,000 in both 2015 and 2016, which amounted to 4.8% of operating revenues. This is on the high end for hospices. For the hospice house alone, the applicant projects that charity care will amount to about 48% of net operating revenue because they'll be providing a sliding scale. On quality, on each of the 2 global measures and the 6 composite measures in the Consumer Assessment of Health Provider and System Performance, otherwise known as CAHPS, Coastal beat the Maryland and national averages on every one of those. Looking at need, there's no prescribed, there's no need projection or prescribed need methodology in our state health plans for a hospice house. So the applicant used a variety of methods to look at need, and in my view, was kind of cross-checking, you know, one methodology against another. They had the help of a consultant's projection who used census and mortality trends for the service area and projected the total patient days of care that would be delivered by coastal hospice programs, exclusive of any residential beds in 2015. The study projected a need for 10.5 hospice house beds by 2015 and 14 beds by 2016. However, that estimate of bed need was based on their projection for coastal hospice's actual days of care or projected days of care in 2015. The actual days of care was 39% higher in 2015 than the consultant's projection. And since then, there was a 19% growth over prior year in 2016 and 9% growth over that in 2017. So the consultant's estimate of 14 beds by 2016 was based on a total pool of hospice patients that was significantly smaller than has actually materialized. They also looked at some of their colleagues that are providing hospice houses, and one of those was Talbot Hospice. And by comparison, Talbot, they found, was turning people away with a 6-bed hospice house that served a service area population of under 40,000. Coastal Hospice is proposing 12 beds for a population of almost, well, more than 5 times that. They also looked at some other hospices that have hospice houses, and they typically had a 16 to 20% use rate. 16 to 20% of their average daily census was typically in the hospice house. Applying that methodology to Coastal's population would yield 31 beds. And finally, they did an examination of the characteristics of their patients and the patient records, and that told them that an appropriate number was 17. So I was particularly impressed with the number of methodologies they used, and certainly it appears that the conclusions that were arrived at were certainly validated by that cross-checking, and if anything, maybe a little on the proposal, a little on the low side. In terms of viability and financial feasibility, the applicant does have access to funding for the project, and despite projected modest operating losses for the first 2 years, when you add back in non-operating income, they go into the black, and that's the hospice house alone. The hospice in total has both a strong balance sheet and strong operating performance. Really no impact on any other providers. So the staff conclusion is that, and recommendation is that this applicant is in compliance with the standards of the state health plan, has demonstrated a need for the 12 proposed number of hospice beds, hospice house beds, has demonstrated the project to be a cost-effective alternative to other options available to hospice patients, shown financial strength and the ability to demonstrate the proposal's viability. So we have a positive recommendation.
Thank you very,
With,
very much.
with us today is the CEO, Elaine Capon, and the Director of Finance, Susan Olashar.
Capon, thank you very much for coming. Commissioners, are there any questions for Mr. McDonald? Any questions at all? Do I have a motion to approve the certificate of need for Coastal Hospital? Do I have a second? Second? Very good. All those in favor of granting the certificate of need, say aye. Any opposed? The ayes have it. Ms. Capon, you have your certificate of need.
Thank you, and I want to thank Vincent and Llewellyn Weidman for their guidance.
Okay. All right. The next item is the repeal and replacement of an existing regulation, COMAR 10-2411, the State Health Plan for Facilities and Services. This refers to the General Surgical Services provision. Eileen Fleck, who is the Chief of Acute Care Policy and Planning, will present the staff's review of comments received on the proposal to repeal and replace the General Surgical Services chapter of the State Health Plan. The staff is requesting the approval of this replacement as a final regulation. These were approved as proposed permanent regulations at our September 19th public meeting. Ms. Fleck, thank you very much for showing up, and you have the floor.
Thank you. Good
Tell us
afternoon,
why we should do this.
Mr. Chair and Commissioners. So there are 6 organizations that commented on the proposed chapter. These are Anne Arundel Medical Center, the American Society of Plastic Surgeons, the Frederick Surgical Center, the Maryland Ambulatory Surgery Association, and the Maryland Hospital Association, and the University of Maryland Medical System. So copies of the formal comments submitted on the proposed chapter are available on the Commission's website. Most of the comments pertain to the exemption process for establishing an ambulatory surgical facility, and several comments were previously submitted and considered by the Commission. I'll review those comments now along with staff's recommendations. Anne Arundel Medical Center commented that the regulations did not appear to address the expansion of an existing physician outpatient surgery center, or POSCs as we refer to them. Anne Arundel Medical Center expected that based on early discussions of the work group and a description of the changes to the regulations included in a separate document, that the exemption process is one that may be used to expand an existing POSC, but that's not directly stated in the regulations. The Maryland Hospital Association also requested clarification regarding whether any practitioner who already operates a POSC with one operating room may establish an ambulatory surgical facility through the exemption process. Staff recommends no changes to the chapter in response to Anne Arundel Medical Center's comments. A POSC with one operating room that adds a second operating room is no longer legally defined as a POSC. Instead, it's defined as an ambulatory surgical facility, and for that reason, the chapter refers only to the establishment of an ambulatory surgical facility through the exemption process and not expansion of a POSC. Staff agrees that the wording in the notice of intent and statement of purpose should be clarified. We submitted for publication in the Maryland Register a revised statement of purpose to clarify that an eligible POSC may establish an ambulatory surgical facility through the exemption process. There are some POSCs that may not be eligible for that process depending on the ownership structure. Staff has concluded that that change will also address the Maryland Hospital Association's request for clarification on the issue. In another comment from the Maryland Hospital Association, it requested confirmation that practitioners or group practices that are wholly owned by a healthcare system are eligible to establish an ambulatory surgical facility with 2 operating rooms through the exemption process, provided that the requirements of statutory definitions are met. Staff recommends no change in response to this comment. We previously addressed that issue with the Commission when we considered adoption of proposed regulations at the September Commission meeting. A subsidiary of a healthcare system that meets the definition of healthcare practitioners or group practice, as defined in Section 1-301 of the Health Occupations Article, would have the opportunity to establish an ambulatory surgical facility through the CON exemption process. The Maryland Ambulatory Surgery Association submitted a comment that also pertains to who is eligible for the exemption process. It suggests revising the language in .06a to explicitly include joint ventures between a hospital and an existing ambulatory surgical facility, a group of surgeons, or a surgical management company. Staff recommends no change in response to this comment because the statute does not permit the type of joint ventures proposed by the Maryland Ambulatory Surgery Association unless the hospital is relocating rooms, operating rooms, that is, to establish an ambulatory surgical facility. Staff received a comment from the University of Maryland Medical System that the proposed regulations adopted by the Commission contain insufficient flexibility in the location allowed for an ambulatory surgical facility when a hospital is converting to a freestanding medical facility. These comments restate most of the University of Maryland Medical System's earlier informal comments on the standard and were previously analyzed by staff and considered by the Commission. The Commission did not make changes in response to those earlier comments, and we are not recommending changes at this time either. Essentially, our response was that there is actually quite a bit of flexibility if they want to go through this process before converting to the freestanding medical facility. So we don't think it's necessary. With respect to the standard 0.06B4C, the University of Maryland Medical System commented that it's unclear which exemption process is referenced. There is both an exemption process for conversion of a general hospital to a freestanding medical facility and an exemption process for relocation of operating rooms from a hospital to establish an ambulatory surgical facility with 2 operating rooms. In response to this comment, staff recommends clarifying language to address the concern raised. The non-substantive clarification recommended by staff is on page 4 of the memo that was sent to commissioners. It's a minor change. The words through and have been deleted and replaced with the words in conjunction with this. I could read that standard if anyone wants me to, but it is on page 4 of the memo. The Commission also received comments on the efficiency standard in 0.06B5. This standard requires that a hospital proposing to establish an ambulatory surgical facility in conjunction with closure of 2 operating rooms must demonstrate that the proposed ambulatory surgical facility will result in an adjusted global budget that is revenue neutral or results in cost savings for payers as determined by the Health Services Cost Review Commission. The University of Maryland Medical System submitted comments similar to those that had previously submitted, which were considered by the Commission, and the Commission did not adopt changes in response to those comments. The proposed language in the standard is consistent with the Commission's goal of reducing hospital costs through the provision of outpatient surgical services in a lower cost setting. If shifting surgical cases from a hospital to the outpatient setting will not result in savings to the healthcare system, or at least be budget neutral, then the proposed project cannot be approved. Staff recommends no change again in response to those comments. The last comment that I want to mention is one from the Maryland Ambulatory Surgery Association on the optimal capacity standard in 0.07A. The Maryland Ambulatory Surgery Association commented that there should be flexibility to encourage the most efficient use of a surgeon's time, and that a business should be allowed full flexibility in deciding how to best utilize its operating rooms. Staff concludes that the standard provides adequate flexibility by permitting an applicant to demonstrate that a different optimal capacity standard should apply to the evaluation of the need for additional surgical capacity. The standard for optimal capacity appropriately incorporates consideration of the efficient use of operating rooms, as well as an evaluation of the benefits and costs of a proposed ambulatory surgical facility for surgeons and patients. The standard adopted by the Commission allows it to make decisions on a case-by-case basis while providing specific guidance on the analysis to be presented by the applicant. That concludes my presentation. I'd be happy to answer any questions, and I'd like to ask that you adopt final regulations that would replace the current State Health Plan for Surgical Services, COMAR 102411.
Thank you, Mrs. Fleck. Ms. Fleck, do the commissioners have any questions for Ms. Fleck? Questions at all?
Can I ask you a question about the,
yes.
COMAR 102411?
Right.
On page 26, it's just a little confusing and ambiguous. They describe ambulatory surgery with not requiring overnight hospitalization, but right below that, number 2, under B, it says the stay is not to exceed 24 hours. That's certainly overnight to me. What capabilities are there in these facilities for observation overnight? Or is that, it's inconsistent, seems to be inconsistent.
No, I think this is consistent with the licensing rules. There was a change to allow for longer stays. It is true that facilities do need to think about what's their staffing going to be, what is available in terms of food services if they're keeping patients for an extended period of time. But this is consistent with the licensing rules.
Well, that's confusing right now, and even in my facility where they have extended recovery, observation, it's very confusing. But this one part says no overnight stay, and then in the second part it says not to exceed 24 hours, which is, in my facility, extended recovery, observation. I think it should be clarified.
I can understand how most people think of overnight as, you know, beyond, you know, like midnight to, or very late until the morning, like you're sleeping.
Well, if you're there 24 hours, you're there overnight.
Right, I can understand that most people see it. I understand the confusion there. I did think that it is consistent with what is permitted.
I know what you're trying to
under
say.
the
It's just
licensing rules.
inconsistent there, I think.
Okay.
Commissioner.
So, one question about, with respect to the budget issue with HSCRC, all we're asking for, as I understood from this, was sort of them to account for how it will fit within their budget. They obviously, we're not asserting any sort of control over how the HSCRC sets budgets for hospitals.
That's correct.
Commissioner Pollak, you had a question?
Down to one microphone, so it's difficult. So, first I want to thank you for an awful lot of work in this process. I think where we are is much better than where we were when we first started this more than a little while ago. And I have I guess a question and a comment. The question relates to the issue of the joint ventures between hospitals and ASCs, and the statutory prohibition, or between hospitals and physician and groups, and the statutory prohibition against that model. Can you expand on exactly what the statutory prohibition is? Because that is a little confusing. There are plenty of joint models around the state right now where hospitals have partnered with physician groups in ASCs.
Right, and so they went through the certificate of need review process. There's a provision in the statute that says if a hospital is going to expand its ambulatory surgical capacity, then it needs to go through the CON review. So that's why we can have a hospital that's relocating operating rooms. It's not expanding the capacity, and it has that greater flexibility to do a joint venture, say, because they're not expanding the capacity.
Does it matter what percentage the hospital owns in the venture? So if the hospital is a 5% partner in an ASC, the ASC, an existing POS, for example, if a hospital is a 5% partner, that POS can't apply for an exemption to become a two-room ASF?
That would be my understanding. It would probably be maybe best for legal staff to weigh in, but that is my understanding because of the way it's written.
I can see the head go.
Yes, that's the way the statute is
the
written.
Okay, that's interesting, and that's the statutory prohibition.
I don't think they care who the owner is. It's just if it's more than 2 beds, it's under regulation.
No, this is all about the owner, because we're talking about the move.
For the exemption process.
The exemption process from one room to 2 rooms is, if it's a POS, if it's a physician-owned facility with 0 hospital ownership, you can apply for an exemption to go to 2 rooms and become an ASF, which is what it would be called, without going through a CON. It's a CON exemption. However, if there's 1% ownership by a hospital in it, you can no longer do that, and you have to go through a CON process and transfer existing, either request new rooms or transfer existing beds. Did I get that right?
Yeah.
Okay.
So if a hospital moves regulated beds out of the OR to another center, and a partnership with physicians.
Yeah, that's different.
That's allowed. That's different.
That's
when
what I'm saying.
when you're
I
not
thought that's what
expanding
you're talking
capacity.
about. Same number of beds,
No.
doesn't matter who the ownership is.
That wasn't the question that I had. The question I had relates to a POS, which doesn't go through the CON process.
It gets a letter of
Physician-owned
determination
facility can just
initially,
go to 2
yes.
rooms without any CON and without moving any existing beds. It can be additional beds into the inventory without a CON.
Operating rooms, yes.
Right, operating rooms, correct. Whereas it's the same model, if there's 1% ownership by a health facility, can't happen. Okay. The other thing the other comment that I wanted to make relates to the volume standard and the allowance of alternative methodology with specific surgeons for the commission to allow alternative methodology to be considered in lieu of the volume standards in the context of a specific explanation and specific direction. And I would encourage us as a group to be flexible in the way that we interpret that. I think there are a lot of situations where physician groups find it very much more convenient and appropriate to run 2 rooms in a surgery center, even when both are running at half capacity. There are ways to manage the cost of that by staffing down. The capital investment is still a little bit higher than it is for 1 room, but it's not twice as high as it is for 1 room. And there may be very, very good reasons why, from a physician convenience standpoint, from a patient convenience standpoint, it doesn't make sense to try and run these things at the 80% capacity that we look for. It may make sense from a global healthcare perspective to run it at a much lower capacity, like 40%, 30%. And I think we need to recognize that as a regulatory body, we don't necessarily know what's best for the small business that is applying to us for this permission, and we need to be very, very flexible in considering alternative models going forward. I'll give the example of a 4-physician practice where you've got 2 physicians who both want to operate in this facility on Thursdays and Fridays, and Mondays, Tuesdays, and Wednesdays it's going to be empty because on Mondays, Tuesdays, and Wednesdays they've got block time in hospitals, they've got other things going on, and Thursdays and Fridays are the only 2 days that both of these physicians can operate, and they want to run a 2-room center for that purpose. We need to recognize that that might be in the best interest of that group and in the best interest of the healthcare system in that area to provide that kind of access rather than have somebody establish 2 single-room pods to do the same thing. And I think I've always, from the beginning, I've been very concerned about that 80% standard that seems to me to be arbitrary and at some level even capricious, that we need to be very flexible in how we interpret that going forward.
Do you have any comment, Ms. Fleck?
Well, I mean, we do discuss those standards with our work group, and the work group did not say that it was problematic to have the 80% standard. There was not a proposal to do something other than what we had been doing in the past.
I think, as Ben just pointed out, we have the flexibility in what's written out to do what I just described. We also have the flexibility not to. And I would just encourage us to use the flexibility to get to a pathway to yes when we have an opportunity to.
All right. Okay. All right. I think that clarifies it. Are there any further questions? Okay. The issue before the commission is the approval of the repeal and the replacement of the State General Health Plan for Facilities and Services, General Surgical Services, COMAR 102411. Do I have a motion? I have a motion. Do I have a second? Second. Any further discussion? All those in favor say aye.
Aye.
Any opposed? Motion carries. Thank you very much, Ms. Fleck. Excellent job, by the way. Okay, commissioners, our next topic has to do with cybersecurity. Welcome to the 21st century. The commission staff conducted an all-state analysis of healthcare breaches, that is, breaches of electronic transmission of information from 2013 through 2016. And they've conducted a prospective review of breaches in 2017. Nikki Majewski, who's, do I pronounce that correct? Okay. Is that right?
Yes.
Is it Majewski or?
Majewski. I mean, if you want to pronounce it Polish way, that's probably.
All right. Okay. What's the correct pronunciation?
Majewski.
Majewski. Okay. The Chief of Health Information Technology, and Eva Lenoir. I got that right because I studied French in high school. Program Manager will present the findings. Ladies, thank you very much. Let's hear the news.
Good afternoon, Mr. Chairman, Commissioners. So over the last few years, the healthcare industry has seen a record number of breach occurrences and records compromised. The industry faces mounting pressures to protect data and keep pace with these evolving cyber threats such as ransomware. These threats have caused a significant growth in breach types categorized as hacking IT, and the trend is expected to continue. For healthcare organizations, it's more than just complying with privacy and security regulations, but it's implementing the safeguards to protect software and operating systems, which is essential, but equally important is changing behavior by end users of these information systems that, can potentially pose a big risk to a breach. As these, growing security weaknesses are consistent with the huge threat. This huge threat is consistent with, we have this multi-layered digital infrastructure that's well underway in Maryland to support care redesign initiatives. So just about the assessment, we looked at breach data from 2013 to 16 and some preliminary data from 2017. This data was obtained from the OCR online portal. This report supplements the one from June 2007 that looked at Maryland breaches by covered entity type and breach type in comparison to the nation. Here we're providing a more detailed analysis of records compromised and location of breached information. These findings will help staff continue to further develop cybersecurity awareness and education initiatives. So here are just some key high-level observations from our analysis in this report, and the last one. From 2013 to 2016, breach occurrences more than doubled, with healthcare providers being targeted most. The largest number of breach occurrences was reported in 2014. This was followed by breaches in 2015 that compromised the greatest number of records compromised in Maryland and the nation. These breaches were primarily attributed to hacking IT. Hacking IT has become more widespread due to the rise in ransomware that often starts out as a phishing scam. And this is noteworthy as much attention is often given to vulnerabilities in software and operating systems, which, if exploited, could give a hacker access to a network. Phishing scams do not exploit vulnerabilities in the system, but the users. It is estimated that about 91% of cyber attacks start out with a successful phish. So to my point earlier, addressing these issues involves fostering greater awareness of cybersecurity best practices. I'll hand it over to Ava with some more information on the findings.
So there are several federal regulations that healthcare organizations need to be mindful of as they continue to implement and update their systems. So HIPAA established a floor for privacy and security protection for covered entities to follow. HITECH later expanded the scope of these protections and enhanced enforcement measures for covered entities and business associates. And this includes requiring information on breaches that affected more than 500 individuals to be reported to OCR and be made publicly available. And the omnibus rule is a final set of regulations that enforces provisions of both HITECH and HIPAA, including placing greater liability on business associates, monetary penalties based on the level of negligence, and breach notification requirements. So between 2013 and 2016, Maryland ranks 10th among states for the largest number of records compromised, with over 2 million records. 3 breaches account for about 94% of the total records compromised during that time period. And these breaches actually elevated Maryland's ranking for between 2014 and 2016 to among the top 6 states, as one occurred each year. And these breaches involved 2 health plans and 1 healthcare provider. The rate of growth for records compromised during this time period increased by more than 200% in Maryland in comparison to 34% in the nation. And this can be largely attributed to a rise in hacking and IT incidents. There have been 13 breaches that have affected over more than 1 million records. Both New York and Indiana actually experienced 2 of these breaches, and for Indiana, this included the Anthem hack that compromised over 78 million records, and is thought to have served as a strong catalyst for healthcare organizations to enhance security protections consistent with other business sectors. And the impact resulting from the Anthem breach actually accounts for over 50% of records compromised between this time period. And interestingly, certain states such as Michigan and Colorado have actually reported more breaches than Maryland, but the impact in terms of records compromised has been much lighter than Maryland, as none of their breaches exceeded 25,000 records. And this illustrates how breaches can occur indiscriminately and have varying intensity, and that it's important for healthcare organizations to improve security measures and reduce vulnerabilities to prevent breaches. And the majority of breaches across the nation have an impact that is lower than 10,000 records. And Maryland, the median is actually lower than the national median at a little bit under 1,500 records compared to 2,300 records in the nation. And so in order to look a little bit more deeply into Maryland's ranking, we looked at states that are comparable to Maryland. Of these states, Maryland ranks third in terms of records compromised. And on average, these states had about 24 breaches between 2013 and 2016, which is similar to Maryland at 23 breaches. However, there was a lot more variability when looking at records compromised. 4 of these states, including Maryland, had a breach that was either close to or exceeding 1 million records. And so on this chart, it actually also includes the Anthem hack for Indiana. And most of these states reported hacking and IT incidents in network servers and electronic medical records. New Jersey kind of stands out because it actually had its biggest breaches resulting from two thefts, one at a laptop and one at an email. And similar to Maryland, Arizona, Connecticut, Indiana, and New Jersey each have 2 breaches that account for at least 80% of their records compromised during that time period, really showing that sometimes one breach can really drive these numbers. So we also looked at breach location more closely to identify some potential vulnerabilities. Generally, Maryland has had more fluctuation in breach location compared to the nation, and there have been some breaches, some shifts over time. So laptops used to be more predominant, for example, in 2013 and 2014, but as we've seen a decline in theft, we've also seen a decline in laptops being mentioned as a location. In later years, with a rise in hacking incidents and ransomware, locations have shifted to email, electronic medical records, and network servers for both Maryland and the nation. In 2015, network servers accounted for 95% of records compromised, largely due to massive breaches at health plans. And so network intrusions can really occur through multiple points of entry, not just through network servers. For example, as Nikki mentioned, a phishing email can trick users into disclosing their system credentials and give unauthorized access into their network. So in looking at 2017 data, so far we've seen that the trends are on par with previous years for both Maryland and the nation. Hacking continues to be a primary breach type, accounting for the majority of occurrences and records compromised for Maryland and a sizable portion for the nation. Healthcare providers reported the vast majority of breaches in 2017. And actually, so far in Maryland, providers have reported all but one breach, which is similar to in 2016 when Maryland was one among 15 states that reported where only healthcare providers reported breaches. And in general, though, breaches this year have been smaller than in previous years. No breach has exceeded 1 million records so far, and Maryland breaches have compromised about 55,000 records, which is a big drop from last year, and so Maryland's ranking is now closer to 16, descending about 10 spots since last year. And the nation has experienced a decline as well, with about 12 million fewer records compromised than in 2016. And so we will continue to monitor breach trends and OCR investigations to identify learning opportunities that we can use locally. We'll also use the findings from this report to continue to develop cybersecurity education and awareness initiatives and continue to work with stakeholders within the community. And lastly, we'll continue to build momentum in providing support to providers and practices to improve their cybersecurity preparedness, to meet evolving demands, which includes increased interconnectability among new and legacy systems as providers transition to alternative care models. Thank you.
Thank you both very much. Commissioners, are there any questions? Commissioner?
Is there any source for looking at the severity of a breach? Because with techniques for segregation of data, you can steal a very large number of records that don't amount to anything, like lists of login IDs without the password, without the underlying data, or you can steal someone's EMR and have their social security number, their medical information, things like that. And I think some of these statistics from some ones I know are mixing those together. It's like a record is a record. In these, is there any source from which you'd be able to say, you know, true identifying or medical information breaches versus ones where the system has worked? There was a breach of the system, but the system was designed such that they still protected the core information. I think that would be really interesting to watch over time to see.
So for the time period that we looked at, OCR did not ask for this information, but they actually do now. So they actually ask when you're reporting a breach, what type of information, so whether it's demographics or clinical information, so we can maybe a bit more assess the true impact of a breach. So that will be interesting to see.
Okay, Commissioner Thomas.
And since so much is determined by where we are relative to trends nationally and other things, can we assume that over the time period, there's been no change in definition of what's a breach or a change in definition? Now we're ranked 16. I mean, we would like celebrate, but you know, was there a change in a definition that makes that really arbitrary, or did we really descend?
So I guess it's important to kind of, our ranking is based on records compromised, so it's kind of a few drivers. In Maryland, there were 3 breaches that drove our ranking. But to Ava's point earlier too, OCR previously didn't really define some of these categories, and as they enhance this portal now where they have to report this information, they're including some more definitions. But so over time, we might be able to see that a little clearer.
I think the basic question of what is a breach hasn't changed significantly. These are more refinements of now we should look at what kinds of breaches, but I think for purposes of this, any kind of personal information going out would be a breach. And I think that's been pretty constant since 2000.
Commissioner O'Connor.
Along those lines of severity of breaches, how many of these breaches become a ransom situation or have any?
So that's kind of a limitation of the data available through OCR. We don't know, but we do about 78% of healthcare providers, a study recently put out indicated they were a victim of ransomware. So we can assume for the most part that the drive in hacking IT is related to these involving ransomware threats, but it doesn't break down exactly if it was an email and exactly how the breach occurred.
But was there a monetary payout for the ransom, or?
Again, we don't really, that's, yeah, it's unknown.
Just on that, so let's pick Maryland. So if a hospital here was held up, ransomed, and they paid the money, they don't have to tell us?
So OCR released some guidance back about a year ago where they kind of, it used to be, the burden of proof used to be on OCR. Now they've shifted it back. If you have a case of ransomware, the covered entity needs to prove beyond a reasonable doubt, like, and as in any breach type that PHI was not accessed. So you have unique circumstances where the MedStar case doesn't show up in this data. But I think while this guidance was issued recently, over the next several years, we'll probably see this continued increase because I think ransomware will fold into this a little more because they'll have to prove that there was a low probability that the PHI was compromised.
I was just going to say, I think that's where I think it's really important that the data start making some distinctions, because it's good to report if there's a chance of data being disclosed. But I think we'd also want to know, well, how many times are there where that was likely or where that may have happened? Because otherwise we're not distinguishing at all between a breach of data we don't care about and it's an ongoing fight between, you know, the Chinese government and large companies, or is there actual data that's harming people going out the door, and how often is each one happening?
I was going to say that OCR stands for the Officer of Civil Rights. You kind of jumped past that, but you know, and that was my first job in the Fed. Now we were doing desegregation and language and handicap those days, not cyber. But at that point, they had the same notion of kind of a complaint-driven system, and they quickly realized that they had to move to something that was more like survey-based and systematic, and so you could, you know, not just wait for somebody to report a problem, have some sort of an information system that would allow you to target problems, hopefully before they happen. So, so I know historically they've had this kind of capability. It strikes me that many of these questions, somebody needs to go out and ask these people, what kind of a breach was it? Maybe give them some anonymity to whether they paid or not, but something more than simply, you know, make a complaint, file a report because there was a problem. You know, it's incumbent upon you, and it is an enforcement agency, so it has very much that mindset. But like I say, at least in the past, they also had the ability to go out, collect data, build kind of a more, you know, were the complaints tracking where the data said there was the problem, or were there some, you know, were nursing homes just not reporting when hospitals were? Any idea that there are any plans to like fill out this picture more than sort of the police report model?
So, I mean, well, part of the limitation to this data is only includes records compromised 500 or more. So some of these smaller breaches, you know, are not included, but OCR also announced plans last year that they are going to start investigating some of these smaller breaches to try and look for systemic occurrences across the board. There's literature out there that suggests who might pay the ransomware. It's hard to get that information from people. But we can take a deeper dive, and I think the portal is evolving, so hopefully maybe more information will become clearer. I mean, there's a lot of people call it the wall of shame and have a lot to say about it, but it is a lot of good, useful stuff that we can.
Right. I guess I was just trying to think, you know, they need more than the one tool in the toolbox to really get a handle on this. And I was just hoping that they were talking about doing something like that, expanding out. You know, I'm just talking about tools that they've used in the past, not asking them to come up with, you know, the space shuttle.
Yeah, we don't have any statistics on the consequences of these breaches. I mean, is this a sore throat or is this a cancer? I mean, it's.
So that's the hard part too. It's hard to measure impact when you look at the OPM breach. I mean, everybody got free credits monitoring for a couple years, so the impact might not be easily assessed until afterwards. And in this day and age, chances are your information's probably already out there, since your socials and all. It's just kind of in healthcare.
On this issue, though, I want to follow up on this. I mean, the data that you put together is from the Office of Civil Rights. By the way, I think it's a terrific report. It indicates that we've got a very serious problem. Obviously, Maryland ranks 10th in the nation in terms of our vulnerability to this right now. Hopefully, you know, it'll be better next year. My question is this, and I mean, sort of, it's an obvious question. We've had 3 big breaches where the enemy got a lot of records, right? I mean, it's kind of an obvious question, but do we know who the culprit is in these big 3 breaches? Do we know who this is?
So that's a great question, Mr. Chairman. There's always an identification of a source, but not always knowing who the culprit is, and it takes time.
Right.
And it's worth noting that a breach can be reported within a year of when it's discovered, and sometimes breaches aren't really found till a year or 2 later.
Right, right.
And the other thing that's notable is that when under HIPAA, all these identifiers, 19-ish or so, are considered protected health information.
Right.
But when the data is breached, it's not because necessarily they want that record from that person, which can often be sold on the black market, but more so to align it with other records from other sources that have been hacked. And if you think of the Equifax breach, and you start pulling data together, it has a greater value over time. And the impact of it, I think, to the question Commissioner Sargent asked, may not be known for 4 or 5 years later. That's why oftentimes these long, drawn-out credit monitoring processes are put in place.
The enemy is building a database.
Yeah, I mean,
what's going on? Now, we know in the case of OPM, or at least we're almost 100% certain, that the breach against the federal government, civil service, which was, I think, 20 million records.
Right.
That's my recollection. I mean, the chief culprit of the Chinese communists who wanted to get that information, that would obviously have a very, very significant national security consequence, possibly for, you know, intelligence reasons later on, getting information about individual federal employees, especially if they're high-level personnel. This thing here, though, the reason why of course, we're all interested in this, and it's unfortunately it seems to be becoming a really serious problem around Uber was breached, for example.
Exactly.
So I'm just really curious as to the obsession with beyond. I mean, the obvious question is the obsession with medical records. It seems to be a national phenomenon. I mean, California has had terrible difficulty here. Indiana is the worst in the country in terms of being a target. I'm just trying to figure out, you know, what the motive of this all is, besides collecting information.
Well, frankly,
Why?
It's because it's easy. If you think about the protections that are put in place, the financial market has the greatest bar.
Right.
And healthcare really has only in the last 10 years or so been moving into more of a technology base where medical records were stored electronically. Historically, they were all paper. And as it gets to be become more technical, the same protections that were advanced in other industries are slowly catching up into healthcare. So hackers would say it's an easy place to go trolling.
We have produced this report, which is going to be widely disseminated. I guess the question is, I mean, this it seems to me that in terms of actually combating this in any kind of effective way, that the capacity to do that is quite beyond the capacity of this commission. Is that correct?
Well, I think this commission is very good at being nimble around the edges of problems like this, and that, as my colleagues noted, education awareness is extremely critical.
Right.
And when you think about safeguarding and not clicking on phishing emails if you don't know the source, don't open it, and having reinforcement by these, what we call covered entities, providers to their employees, and continuous reinforcement can go miles to really safeguarding an infrastructure without necessarily implementing millions of dollars in technical safeguards. So I think the strategy has been, under your all's leadership, is education and awareness. And we're probably best suited to do that. And we're really good at bringing together stakeholders so they can begin to trade ideas and best practices amongst themselves. In fact, Nikki has done several of these events around the state over the last couple of years, and they've been very successful and well received. And this report will be a great framework for drawing interest in.
No, it's an excellent report. Congratulations to you all for putting this together. Are there any further, Tamarkio, Commissioner Tamarkio?
So on your next steps, they're pretty softball next steps.
Mm-hmm.
These are probably three at the top. If you were to go stretch a little bit, what would be additional next steps that could actually, might not be as comfortable to do, like monitor and continue awareness, but will actually have a deeper impact on controlling the issue?
Encouraging healthcare organizations to conduct more regular risk assessments beyond the minimum required. You know, if you just conduct one, you're more vulnerable those 11 remaining months of the year. And as we've seen from our hospitals, that we really look forward to, you know, what are some of the best practices that the smaller practices can follow. Hospitals have conducted more regular risk assessments, and they're kind of, you know, just diffusing this information into organizations more regularly. So that's one of the things that, you know, that's really kind of requiring them to change, and that's one of the harder things we can, especially with smaller practices when they're balancing a lot of other things.
But I think if you're going to ask an individual to provide a plethora of information about themselves, about their medical background, their medical history, their family's medical history, then you have a certain responsibility to control that information in an ethical way. And I don't think it's unrealistic to say that you need to check it more than once a year, your vulnerabilities.
Agreed. We agree. Thank you.
Are there any further questions?
My medical providers are the only kind of people I deal with electronically that still ask me for my social security number. Sometimes my bank, when it's actually, there's tax documents involved. Is there any real, is that just a legacy of old days when people were not that careful with their social security number? I mean, because that seems to me, in a breach, that's often the prize. Do we have any notion, I mean, when we talk about advising small practices, why, I mean, most people, I think, still report it. I mean, I scramble mine, but.
I think it makes it easier to do when the bill's not paid. I'm serious. I think that most of the medical providers that collect your social security number, it's not that they needed to treat you. It's not that they needed to collect payments from insurance companies. It's because they're putting it in the file in case there's an unpaid bill and it's connected.
Yeah, because when you think of on the claims perspective, as Commissioner Sturgeon pointed out, it's not a key component for adjudicating the claim. And so it's probably more at the practice level, and maybe other commissioners have experience with that, but it's not a required part of an EHR.
Then would it be, is there any aspect of it that would be problematic? And when we're talking about making recommendations, how to improve security? To make a recommendation that there's certain information that unless you're really gonna have redundant, triplicate kind of systems, you probably shouldn't be asking patients for?
Good point. That's a good point.
I mean, I'm sure any of my providers can find me if they need me if I didn't pay my bill. It's not like I'm living out of a trailer and moving around the country.
Yeah, it's a good point.
Yeah, but you. So I mean, I'm just thinking of easy bits that might help. I mean, and when you brought up, is there something more we can do than, you know, have another study in 3 years or something like that?
One thing we can do is encourage people not to give it out. I just write NA on that line.
Okay.
And these are
none of your business.
Pretty much.
Okay. Yeah, very good point. Thank you. We will make that part of the practice.
Director Stefan, you have
So I think that our authority here is pretty limited. I think if you have some good ideas, we will certainly welcome them. With regard to the social security number, it is somewhat of a contradiction that because there's no national patient ID, we've seen the development of master patient indexes that are used by health technology companies, developed by health technology companies, and then used by insurers, providers, et cetera. And those master patient indexes invariably, for the most credibility of the MPI, that's weighted by the fact that patients, you have a social security number for that individual because in comparison to the telephone number, address, et cetera, date of birth, the social security number is one thing that the indexes judge as highly reliable for authenticating patients as they move through the information systems, which increasingly involve providers who don't have direct face-to-face contact with you.
Let's not forget that every time that we go to see a doctor, they're also taking a copy of our driver's license. And with that number, it connects you to another source of information. So it's when you take a step back and look at how much information we are willingly giving over to another human being, and human beings have heirs to them, it's unbelievable what we willingly give to people and are forced to give because of situations that, well, you can't see the doctor if you don't give me your driver's license.
It's called.
Right.
That's more for a picture ID than your license number per
That's
se.
for their use.
Right.
But that information is now housed and it's now available. So I just leave that there.
All right. Are there any further questions or observations? Ladies, thank you very much for a terrific presentation and a great report. I think we have a lot to think about. Our authority in this area is limited, but I think the educational program that we've been conducting, Mr. Sharp, I think we ought to, figure out some way to maybe double down on that with some of the, I'm not exactly sure what else we can do in this area. I'd also be very interested in finding out if, in fact, there is a main enemy, a culprit that has really been hitting us, especially these big breaches that we've suffered that put us number 10 in the country. I mean, I'm curious about this, and I think every member of the commission probably is.
Well, and whether there's any convictions.
Right. Oh, yeah, absolutely. Thank you very, very much. Our next item has to do with Maryland's hospital quality and patient safety. As you know, on October 31st, Leapfrog, which is a nationally prominent institution, released their 2017 hospital patient safety grade results. And for the very first time, Maryland hospitals were included in this national ranking system, the national scoring system. You will also remember, I think it's all seared on your memories, that the results were not as positive as we had hoped. Nonetheless, this is an important first step. You cannot correct a problem unless you understand the extent of it. And Leapfrog has helped us to actually get a handle on how far we have to go. During the meeting, the last time we were together on this, we agreed that I would request the Maryland Patient Safety Center to speak directly to us on how they plan to respond to these disappointing results. Earlier this week, Commissioner Phillips and the staff of the commission and I met with Dr. James Rust, who's the chairman of the Maryland Patient Safety Center, and Mr. Robert Imhoff, who's the president and CEO of the Maryland Patient Safety Center. And we had a very, very frank and cordial discussion, a very, very detailed discussion on the challenges that we all face here in the state of Maryland, and heard about what the center plans to do to work with hospitals to improve our situation. We've asked Mr. Imhoff to come back. He's back today, and to more fully describe the center's efforts for assisting Maryland hospitals. We have a lot of work ahead of us, Mr. Imhoff, and thank you so much, gentlemen. Thank you so much for showing up, sharing the time with us today.
You're most welcome.
I'm sorry, I didn't get the ladies.
So, good afternoon. This is Bonnie DePietro, our Director of Operations for
Welcome,
the Maryland Patient Safety Center.
Thank you very much.
And Mr. Chairman and respected commissioners, thank you for this opportunity. It means a lot to us. My name is Jim Ross, and I have the pleasure and privilege of chairing the Board of Governors of Maryland Patient Safety Center. And together with Robert Imhoff, we look forward and we're honored to be here to provide you with an update on the work that we have done and that we continue to do. I'll say up front that we very much share the Commission's view that there's nothing more important to us than improving quality and safety outcome metrics for our patients. Indeed, it's our mission to make healthcare in Maryland the safest in the nation. And that we look forward to providing you with this update and also exploring opportunities to work collaboratively. I want to start with a little bit about our board. And our board, as you can see here, has a very diverse group of 22 board members on our leadership team. I'll just call your attention to the newest board members, which are in bold. We have a representation from a variety of disciplines, inpatient, outpatient areas, and all major healthcare systems are representative. We also have national representation from patient safety experts in both Drs. Marty Macri and David Mayer. And we also have strong representation from the patient advocacy field, very active, engaged members on our board. These are our 44 dues-paying member hospitals. Our next slide is we're proud to have 41 members in our federally listed patient safety organization. And finally, our strategic partners. These are some of our strategic partners we've aligned with to help us with our efforts, our initiatives, our collaboratives. And as you can see, just to call out a few, we have representation from ambulatory, from long-term care. You also see the Vermont Oxford Network, which is the international leader in quality and safety for neonatal care. Chris, the Berkeley Research Group, or BRG, who is, we entrust with our analysis of data, Johns Hopkins, and so on. So at this point, I'll turn it over to Robert to discuss our initiatives.
Thank you. It's a pleasure to be with you all again. Just start off, give you a little briefing on what we're doing currently. We have a perinatal neonatal quality collaborative, which at present is focusing on neonatal abstinence syndrome and the reduction of first-time C-sections. As an extension of our sepsis efforts, we are working with the long-term care and HQI in reducing sepsis and identifying sepsis, again, with the long-term care community. Our CLEAN collaborative is focused on reducing health care-associated infections through an educational and practice collaborative around reducing surface contamination. Errors in diagnosis, we are working with the national group, the Society of Improved Diagnosis in Medicine, around this issue, which was highlighted in the 2015 report by the Institute of Medicine. We're working now on determining the scope of errors in diagnosis within the state of Maryland through working with Dr. David Newman-Toker at Johns Hopkins. We are about to kick off our opioid misuse initiative, which is a three-pronged approach around consumer, physician, and medical student education. This is a collaborative program. We're working with a group at Hopkins and also MedChi. Our Care Alerts initiative is a collaborative effort with CRISP. They started a Care Alerts program some time ago. We are now in charge of the second iteration of this, where we are clearly defining what Care Alerts are, how they're used, and used by whom. This is an effort to reduce utilization in the ED. We have been talking with HSCRC about an initiative around ED wait times and throughput. We're waiting to hear from them as far as what their priorities are in determining the exact scope and direction of a collaborative. Medication reconciliation, we're working on a toolkit to determine better information from the patient toward reducing utilization and readmissions. And then adverse event reporting, as we have discussed previously with you all, we have now 11 hospitals reporting just over 20,000 incidents, which we analyze and determine trends. Some recent highlights, our C-section initiative showing 293 fewer primary C-sections through second quarter of 2017. That's derived from vital statistics. Data preliminary, however. Our first phase of the surface contamination or CLEAN collaborative showed 113 fewer cases of C. diff in the 18 participating hospitals. Our NAS initiative showed a 56.7 reduction of transfers of those infants to higher extended levels of care. One of the goals of this is to keep the babies in the community and to reduce transfers to higher acuity and more expensive care. Our sepsis cohort 1 showed a 12% decrease in mortality, and cohort 2 a 22.6% decrease, both through HSCRC data. Again, I mentioned we have over 20,000 adverse events from 11 facilities. We are talking to several more hospitals. We have currently 18 licenses available, and we are talking to the entire University of Maryland system about taking their adverse event data, which includes, I believe, 12 additional hospitals. Will obviously extend that license. Our Caring for the Caregiver, which is a cooperative program with the Armstrong Institute, which highlights and addresses the second victim phenomenon, is now in 8 facilities in the state and in other states. This is one of our fee-for-service programs, one of our earning revenue generating programs that we are marketing nationwide and have had significant interest from hospitals from California to New York to Texas, Florida. We were recently relisted as a federal PSO through AHRQ, and that extends through 2020. And we have recently contracted with BRG to assist or take the lead in our data analytics. We realize this has been one of our deficiencies, and the board has made the financial commitment to engage them so we have a higher integrity, higher level of data analytics. So we were talking about the leapfrog situation, our concern, this is something that was discussed has been discussed at the board level and continues to be. We take these quality measures very seriously. It's what we do. It's what we're about. Some things that we are working on currently, medication safety, as I mentioned, the opioid initiative, medication reconciliation, the toolkit that we are in process of developing, maternity care, previously worked on early elective deliveries, which concluded in 2013, and we are now again working on first-time C-sections. High-risk deliveries, we're partnering with the Vermont Oxford Network on the neonatal abstinence syndrome, again to decrease length of stay and transfers to higher acuity facilities. Our hand hygiene was concluded in 2014, managing serious events, which is related to our submission of adverse events, and then healthcare associated infections, both the hand hygiene and then the Clean Collaborative, which reduces surface contamination rate. So all of that's well and good. However, how do we move forward? What opportunities do we have available to us? And we do see this leapfrog situation as an opportunity to hone in on specific measures and to work toward improving those and work toward making greater impact. We don't anticipate teaching the test, as it were, for leapfrog, but there are very valuable measures in there that the Maryland Patient Safety Center and its partners, hopefully additional partners, can work toward in improving those rates. We have been, and this is something we discussed in our meeting the other day, we have been taking more of a shotgun approach to addressing readmissions and length of stay, utilization rates, et cetera, which are all very important to our members and also to the all-payer model. However, it's in our discussions with HSCRC and also with the commission, I believe it's time that we reevaluate that and maybe take more of a specific collaborative, specific issue approach to these issues, especially those around the leapfrog. We need to identify and urge greater participation. All of our programs are voluntary. We have no authority to mandate, though our partners, such as the commission, I feel could encourage and help us in that regard. And we probably should look to the outliers and identify those and be more involved in that. Increased collaboration between the stakeholders. Again, something we discussed the other day. I would really enjoy seeing a meeting between all the shareholders in this regard so that the approach is more collaborative and more cooperative rather than everybody doing kind of their own thing and working in very oftentimes separate directions toward accomplishing the same goal. I think if there were greater coordination and greater efforts working together, I think we could show some more significant improvement in these measures, in all safety measures, actually. Increased involvement of patient and family advocates. As Dr. Ross mentioned, we are addressing that at the board level with two very high level and including that as a greater part of our discussions and a part of our decision making. Of course, continued support of the all-payer model, which is very important to our membership. Our certification program has proved very helpful for the few institutions, the test institutions that have accessed this. This is a program I could take your entire afternoon talking about, which I will not take your time doing. But it is a program that addresses patient safety culture and specific patient safety issues within those organizations and has been very successful. This is another tool that we have available to us to help the organizations move forward with their patient safety efforts and also addressing specific patient safety outcomes. Building capacity, as I've stated before, we are a small organization with a limited budget. We have limitations in our resources, which limit our ability to involve ourselves in more than we do. The greater that increases, the greater financial resources available to us and staff, the more we would be able to do. We are working on earning more money, as it were, with fee-for-service programs to help us in our mission. That is moving forward, but it never comes fast enough, and it's something that we continue to work toward and again, help build that capacity. We are taking a position of collaboration and cooperation, not competition. Patient safety is not accomplished when everybody's working either in silos or individually or against when there are competing efforts. Patient safety is accomplished and impact is made when everybody works together. Ben, remind me of your quote, success is not solo, and especially here in patient safety. Everybody has to work together. Everybody has to be part of the equation. That's what we preach to our providers, that patient safety is everyone's business and everyone has a role in that. And that's how we're going to make a difference. Short presentation made. We'd be glad to entertain questions or comments. Thank you.
Thank you very much, Mr. Unhoff and Dr. Rust and Mrs. DePietro. I got it. I'm sorry. Listen, I'm glad we had our meeting earlier on in the week to talk about this. Some of us have been talking privately. I know I had lunch with Commissioner Thomas earlier this week, and one of the points that we share, one of the observations we share with each other is that the Commission has a kind of broad responsibility, and improving access and controlling costs is part of it, but also improving quality of care. I think that when we received the data from Leapfrog, I think a number of us were really profoundly disappointed in what they were reporting. I don't think there's anybody on this commission who has not been affected by that in terms of our own private conversations with each other. We're here to do the very best we can, and this information has come to us on our watch. And speaking for myself, I agree with you entirely. This is a collaborative effort. We have to work together. We have to do the best we can to make sure that we bring as many of our friends and allies in this battle together in the on the same team. The last thing we can do is try to run a play where we're tripping over each other in the backfield. This is something that's really going to require a great deal of cooperation, and I thank you for the spirit in which you've approached this issue. Because
and I appreciate that also. This has come under our watch too.
Yeah.
This is of great concern to us.
Right.
We know we can do better. Despite it being 2013 to 2015 data,
right.
It still indicates a trend that we need to reverse, and we're prepared to do that.
Right. I really appreciate that, Mr. Emhoff. I really do. Commissioners, do you have any questions? Commissioner Thomas.
You know, when the Leapfrog people came here, I pushed back hard on them. I've seen these rankings, and sometimes they're rank and spank, press release, big news. Okay. But I have since been convinced that they're a valid and reliable organization. So if you agree that they're also a valid and reliable organization, on the day that that report hit the newspapers, what happened at the next board meeting? Was it on the agenda of the next board meeting of your organization?
It absolutely was.
Okay. And what happened? Give us a little flavor of what happened.
We discussed that, and we realized that it was a call to action and something we needed to take a more specific approach to. We discussed we had honestly dissenting views on the Leapfrog report. We had some board members that were in greater agreement than others. There were opinions around the room about the report, but generally the tone, the climate was that it's an opportunity, and certainly to put us in a direction, and that there are measures that we need to be addressing.
The worst part is the results are so dramatically different than how we think of ourselves here in the state of Maryland. And I'm sure how you think of your organization, that we don't rank that way. So some of the things that you mentioned don't really cost money. I mean, money can help, more data can help. But getting all those members in a room and telling them to set their swords aside and cooperate on this, we might be able to move the needle in our lifetime. And that's what we're calling for.
I couldn't agree more.
do you think that this commission can help create the atmosphere to get them in the room?
I think this commission can. I think that commission can. I think MedCai can. I think the payers can. I think everybody can, yes.
So I would like to think that right now we're reacting, to this report. But if we can come out of this more proactive, we might get something that none of us could have done independently. So if there are any barriers to getting that room and the right people in it, I'd like to know now so that our chair can talk to his counterparts and we can actually get a date on the books and a planning committee to actually make this happen. You think that's possible?
I do think it's possible, and I would encourage it moving forward. Thank you.
Commissioner Flake.
Thank you. With the limitations you spoke about that you have, how do you specifically know that you have an effect on anything? And I mean, how do you measure what you actually do to see if the outcome is really a result of things that you're doing?
That's a very good question, and it is not the first time the question's been posed or the first time we've answered, but it's an honest and I think a very fair question. We go very specifically. I'll take the NTSB, the C-section rate decrease that we've had in the work that we're doing around there, and Bonnie can elaborate on that. But as far as the data is concerned, as far as the data on the other collaboratives, we started a baseline where results are, and then we move forward with the shared learning and the opportunities that we have, expert faculty, change in practice, things like that, and we see declines. Some are more ambiguous than others. The hand hygiene, for example, we saw a corresponding decrease in HAI rates over the same period. We realize that's not the only factor contributing to a decrease in HAI rates, but we all know common sense dictates that is certainly a contributing factor. So as we see that compliance rate increase and we see HAI rates decrease, we feel that we're a strong contributor. The same with the Clean Collaborative. When we see the 18 participating hospitals show 113 fewer cases of C. diff with corresponding increases in or improvements in surface contamination for the good. I hope you understand. We feel that we've had a strong contribution in that regard.
And if I can just follow up, prior to the birth of any collaborative or any initiative where we're collecting data, subject matter experts are brought together. All initiatives, all collaboratives are approved by the board, and we have subject matter experts who speak to these on multiple occasions as well, where we're looking at hard data, outcome data, process data, depending upon the collaborative. So your questions and your points well taken, but we are a data-driven organization.
Commissioner Tamacchio.
So in reviewing the leapfrog data, talking about it amongst the group, are there maybe 3 key things that popped out at you as trends that that either are noteworthy or actionable?
Well, I feel they're all actionable. The HAI data was something that popped out at us because that's something we've been working on for some time with different collaboratives. Again, what we're doing contributes to that. It is not, what we're doing is not a panacea. It's not the magic wand to totally reduce HAIs. We can only take, with all of what we do, we can only take different segments and different components of these issues and do what we can to make impacts in those areas. I'm going to refresh my memory if I can go back. We're looking at all these different areas right now, again, with more of a shotgun approach as far as, well, the HAI, I think, was the most important, or I shouldn't say the most important, which caught most people's attention. because that's something we've been working on diligently for some time.
Any further questions? Yes. Oh, sorry.
Thank you. Just to
Commissioner-
focus a little bit more than on trends. You know, there'll be another year and we'll see another report and we'll see more data. What are the 2 or 3 things that you're committed to that you'll address and have a change within, specifics over the next 12 months that you go, there's the low-hanging fruit, or there's the most important one we can move in. Something so that when we talk again in 12 months, you say, yeah, you know, here are the 6 problems, we've taken care of number 1 and 3.
Well, it's difficult to address because we're now in a multi-year approach with many of these collaboratives. We'd like to sit down with the other stakeholders and figure out where we can identify that low-hanging fruit and how we can work cooperatively and make an impact in that. We don't have, at this point in time with this discussion with you, a specific plan as to how to address specific measures within this leapfrog beyond what we're doing now. So again, I don't think it's something we do alone. I think it's something we do together with the other stakeholders and the other entities involved.
The only caution I would say is that, you know, we always know on this kind of data collection and then the time it takes for them to analyze and report, we're already in they've already got a few months here. You're like presidents who kind of flirted away their first year and wonder why they are at year 4 and haven't gotten anything accomplished. The clock's running.
Right,
and if you expect to have an impact,
either we need to drop some things and refocus. That is certainly a possibility, and that's something we'll address at the board level. Do we move on from other things that we're already involved in and get involved with specific issues around the leapfrog? That'll be a topic of discussion. And Jim, you might want to expand on that a little bit from the board level.
Give me a little more color.
About round, do we change our focus kind of midstream with some things, or do we move on? And again, that becomes a board level decision and a resource allocation decision. I'm sorry.
No, that's okay. That's okay. So I might say that we are in the midstream of several collaboratives, the neonatal abstinence syndrome collaborative, and to stop that one, or a sepsis collaborative, to stop anyone might throw a wrench into what we're doing. I think that a lot's going to come out of our discussion with you and other stakeholders as well as to our direction. And I think one of the opportunities we have is to leverage your influence, because we clearly won't, it doesn't matter what we have planned starting tomorrow or tonight, if we don't have the leverage to be able to create the not just sense of urgency, but also demand action by our state's facilities, we can't move the needle.
Mr. Director.
So I was struck, and this line of questioning is going to be very much similar to Commissioner O'Grady, which was I was struck by your comment that we have a shotgun approach, and I think probably with recognizing with limited resources, that's especially challenging. I would challenge you to think of more targeting, particularly as it relates to some of the leapfrog scores last month, the CMS 5-star scores yesterday. Demonstrates there's a lot of work to do here. The CMS 5-star scores, not narrowly focused on patient safety, but more broadly on quality, do suggest there's a lot of work to be done. The shotgun approach, I think, is definitely poses some challenges that old healthcare reformer Napoleon Bonaparte said all force at the critical point. So I would challenge the board to think with more specificity on, yes, we can approach this across the broad front, but maybe to everyone's points here, rank by priority 5 or 6, and target those. I think it would also give us a more meaningful way to attach see your initiatives in hearing about Ken. Lastly, the point I would also make is that I heard you say we're waiting for HSCRC to act. A patient safety organization maybe shouldn't wait. So maybe they're going to help, maybe they're not going to help, but if ED throughput is important and you think it's important, you have to think of another way to act. And I think waiting for state agencies, the wheels of government, I'm filled with cliches at 4 o'clock on Thursday.
Well,
but, it turns very slowly, and you have the flexibility and the nimbleness that government doesn't, and you should execute on that.
I agree. And given my druthers, we would have started something a month ago. However, we don't want to enter into a collaborative or an initiative that's not going to be focused on proper priorities or with proper partners. So we are a slave a little bit to what goes on elsewhere. We can't just, as much as we would just like to move and go forward with something, we are required in some model of efficiency to see where the priorities are and what tools and what resources we'll have access to implement that. And as far as the first part of your statement, we couldn't agree more. This targeted approach has been discussed at the board level also. So it is not something that we aren't aware of or on our radar screen, and it's an approach we're taking very seriously.
Okay. Commissioner Thomas.
So just briefly, I'm actually encouraged by your observation that you don't have all the answers. You got an impressive board, but you don't have all the answers. I think just acknowledging that is an important step. Secondly, the fact that you acknowledge that there's not consensus on your board about that particular report. And it doesn't make sense to teach to the test. I think you're absolutely right. These are very, very complicated. But if this commission, with our chair, can help convene, I want to make sure that the people in that room are not just the people who, I'll put it like this, I want to make sure that the people in that room are at the top of the food chain, because it starts from the top. And if I could, and I have a sense from your testimony here that you will make sure that the people in that room are the right people to help move the needle.
Selfishly, it's only to our benefit. Right. If we get the right people involved and we get decision makers and the people that want to do this, it will do nothing but help the Patient Safety Center in our efforts. We are with you all 100% about making impact and making change and putting things in a positive direction. There's no dissent from the Patient Safety Center about this. And as far as our board disagreeing, maybe with some components, some pieces of the leapfrog, that's all well and good, but nobody's in disagreement about these quality measures being the best they can be within the state. So that is not an area of contention at our board level. Thank you.
Any further questions? Mr. Imhoff, I want to thank you very much for spending time with us this afternoon. I think, I think Commissioner Thomas sort of made the observation that sort of was really most important for all of us. I think Maryland has a sense of self-esteem, and when the report came out, the metrics it damaged our self-esteem in terms of how we're doing in the rest of the nation. General Bonaparte was mentioned as a model. The great American philosopher George C. Patton took the position that when you do get the tanks and the gas together, that you hit as hard as you possibly can. I just want you to know that we're ready to enlist with you.
Thank you. We appreciate that, and we will certainly take you up on your offer.
Okay. Thank you very much.
Thank you for your time.
Merry Christmas, Mr. Imhoff.
You also.
Ladies and gentlemen, the next subject is nursing home quality ratings. and the relationship between them and planning and certificate of need regulation. Over the past month, commissioners and staff have had discussions on how the CMS nursing home compare star rating system could be used in our nursing home state health plan. The staff offered to review the Maryland nursing home performance under the CMS system. Linda Cole, Chief of Long-Term Care Policy and Planning, will provide an overview of the CMS nursing home star ratings and describe the construction of the overall nursing home star rating and explain how Maryland's jurisdiction on this system can be improved. As we found with hospitals, nursing homes in Maryland have considerable room for improvement. So it's another matter of how we can develop a higher level of self-esteem in this area, right? Linda, thank you very much for all of your work in this area. We really, truly appreciate it.
Thank you. I don't know if I can follow General Patton, but I'll see what I can do here.
Get out of his way is what you do.
Okay, as was stated, we're in the process of updating the nursing home chapter of the state health plan. As with other chapters, we're trying to focus on quality, especially standardized and publicly reported quality measures. I would like to thank Teresa Lee and Julie Deppy of the Center for Quality Measurement and Reporting for their work in developing the tables. Some of these tables may be difficult to read as slides, but they are also available in your packet. So this will be a brief update on the development of nursing home star ratings and their application and certificate of need review. I'll provide an overview of the ratings, show Maryland nursing home star ratings by jurisdiction, provide a comparison of Maryland to neighboring states, and also show the ratings by corporate affiliation. Nursing home star ratings have been in place since 2008. Although they're not perfect measures, CMS has tried to update them periodically, most recently last year, and to provide multiple sources of data so that they're not just self-reported. The overall star rating is made up of three components. These include health inspections, staffing, and quality measures. The health inspections are derived from annual state surveys, and the results are based on the number, scope, and severity of the deficiencies found during the most recent 36 months. This is the core of the overall rating. Measures are based on comparison within a state. The second component is staffing, which is based on RN hours per resident day and total staffing hours per resident day. These measures are case mix adjusted, and the data is self-reported by nursing homes. The third component is quality measures. These are derived from the minimum data set, MDS, and also Medicare claims data. These were updated in July 2016 to provide more measures for short stay residents. The star ratings here are based on performance on 9 long stay and 7 short stay measures of the 24 total measures that CMS posts on Nursing Home Compare. And these measures are risk adjusted. So the overall star rating that is calculated by CMS begins with the health inspection rating. The next step is to add 1 star to step 1 if the staffing ratio is 4 or 5 stars and greater than the health inspection rating, and subtract 1 star if the staffing ratio is 1 star. The next step is to add 1 star if the quality measure rating is 5 stars, and subtract 1 if the quality measure is 1 star. And the overall rating cannot be more than 5 or less than 1. If the health inspection rating is 1 star, the overall rating cannot be upgraded by more than 1 additional star. I realize this is a bit overwhelming, and again, in your packet, there is the mechanics of how this is done. Since CMS considers 1 star much below average and 2 stars below average, the following tables focus on the percentage of facilities ranked as 1 or 2 stars. This slide shows an overall star rating by jurisdiction in Maryland. Focusing on the highlighted column, you see the percentage of jurisdictions with 1 and 2 star overall star ratings, and it ranges from 0 to 100%. It should be noted that the one jurisdiction, Queen Anne's, that has a 100% 1 and 2 star rating also only has one facility in the jurisdiction, so there's not a whole lot of consumer choice there. This slide compares the percent distribution of nursing homes with 1 and 2 star rating, overall star ratings, in Maryland with that of the nation and neighboring states. And it should be noted the lower percentage is better because we're looking at low star rating. 30% of Maryland nursing homes with 1 or 2 overall star ratings perform slightly better than the national average of 32%. We don't perform as well as DC and Delaware, but it should be noted that DC has a total of 18 nursing homes and Delaware 45 statewide. We do perform better than Pennsylvania, Virginia, and West Virginia, and this pattern holds for the 3 years for which data is shown. Many nursing homes in Maryland are part of corporate chains, whether Maryland-based or national. For this slide, we excluded continuing care retirement communities and also corporations that had only 1 facility in Maryland. And again, we focus on the percentages with 1 or 2 stars in the overall star rating. Again, they range from 0 to 100%, and half of the corporate chains show 45% or more with 1 or 2 overall stars. This slide presents the same data as the previous one, but provides data for 3 years. There are some variations from year to year, and we will probably use more than 1 year of data to develop standards. As I mentioned, this is just a brief introduction. We will be working on applying this data to develop docketing rules and CON review standards for the nursing home chapter of the state health plan. We'll begin that process with a work group next month, and we will be back to update you on the process. I'd be happy to answer any questions.
Thank you very much, Ms. Cole. Commissioners, do you have any questions? Yes. Commissioner Phillips.
Thank you very much. This is a really good report, and I realize this is not the purpose of manipulating the CMS data is for applications for CON reviews, but in and of itself, the display of the nursing home ratings by jurisdiction is new. I don't think that that's publicly available in one place. I looked, for example, for Anne Arundel County, and the CMS website is impossible to navigate to look as a county as a whole. How are we doing, and what the rankings are of the nursing homes in the county. You can do it within, I guess, a 5-mile radius, or it's just not a platform that would allow for this kind of review. And so I just think it's marvelous, and I would like to share it with health officers so that they have the opportunity to get that kind of visibility, and I would think other users would be very interested in this as well. So thank you for this. I imagine this will be up on the commission's website and will be updated.
Yes, and as I mentioned, the staff of the Quality Center was able to get into the CMS downloads, and
that's fantastic. And it's really good work. So we'll put it to good use. Thank you.
Any further questions? Thank you very much, Linda. This has been great. Ben, would you like to share any upcoming initiatives for next January? What we're going to be dealing
So
with?
you already know that Kevin will be back before you with a CON modification. In addition to that, normally in January, we provide an overview of the legislative process. Those that have been with us for a number of years know what that is, but I will be most likely doing that in January as we are in the recruiting process for our public relations and government relations person right now. We hope to have that person on board by the end of by the January meeting, but don't know. Tiana will also, I've stalled her off, will be before you for the first time to present on the outpatient quality initiative. She has been doing some field work and is going to bring you, present to you a long-term plan on how we intend to go forward with that. And David's team will be talking about the telehealth grant award, the most recent iteration of that. We'll also most likely be talking about what I said at the outset. One, the total cost of care, hopefully agreement signing with the federal government, and two, somewhat different, but again, the same term, total cost of care report from the Network for Regional Health Initiatives, where Maryland has done, as I said, again at the outset, quite well, consistent with some of the alignment there is in Maryland with the all-payer model historically, and that has yielded some benefits for privately insured Marylanders. That concludes what I have to say. So I'll turn it back to you.
Thank you very much. It's very accommodating, Executive. Ladies and gentlemen, before we close, I just have a couple of remarks, very, very brief. 2017 has been I think, a great year for the Commission. We've undertaken a groundbreaking initiative in price transparency, which has gotten attention not only in the local media, but around the nation. And we've taken some very, very big steps on trying to get a clearer idea of the performance of our institutions in terms of quality. And we're undertaking regulatory reform in 2018. This Commission has a great deal of work ahead of it. 2018 is going to be a very, very, very significant year if we continue to work as well in 2018 as we have worked in 2017. For myself, I just want to express my deepest appreciation for the outstanding professionalism and dedication of the Commission staff. And in terms of the commissioners, all of you, your engagements, your willingness to engage deeply on these issues, to do your homework, and to engage in civil debate, I think is a model for the way in which public bodies should operate. So with that, I just want to wish everybody a Merry Christmas, Happy Hanukkah, Happy New Year, Merry everything. God bless everyone. And this meeting is adjourned. I don't need a motion.